Okay. I think we are live on YouTube also.
Okay.
Let me check once. Yeah, we are there. Now you can stop sharing. Anyways, once we start discussion, you can. Okay, fine.
Yeah.
Good evening, Kundu sir.
Sir, good evening.
Kundu sir, back from the trip.
There is always most of the times on the aero bridge.
Yeah.
हेलो
Yeah, good evening, sir.
आपका बात सुनाई नहीं दे रहे हैं
Are you able to listen to me, sir? Okay, निखिल, आवाज आ रही है मेरी?
Yes, sir. Yes. अच्छी
तो-
तरह आ रही है.
तो कुंडू सर, आपका कुछ वहाँ प्रॉब्लम
क्या
होगा.
हुआ
आपका आवाज आ रहा है?
हाँ हेलो एवरीबॉडी इज देयर
Yes, sir.
Yes, sir. Good evening, sir.
और मनु कैसे हैं? All good?
All good, sir. Enjoying Bangalore weather.
Yeah, Bangalore is good.
It's really nice. Unless you have to travel, then it's
Yeah,
another
that is true. Yeah,
story.
it's a biggest parking lot. When you see from the satellite, it looks the traffic is moving, but you feel that it is a parking lot. It is said for Bangalore, everybody is saying like that.
You better live very close by to your work, otherwise you're stuck.
Yeah, but now everywhere is the situation is same, at least in peak hours,
Yeah.
whichever way you go. So all metros, all bigger cities are the same thing.
It's the same, yeah. True. Hi, Dr. Bala.
Good evening, Bala sir. भास्कर अभी तक ज्वाइन नहीं किया.
भास्कर सर की ओपीडी हो गई क्या?
Yeah, so वो
And Mihir sir is there.
Hi, Chetan, Manu,
good evening, sir.
Dr. Giri,
Good evening. Good evening,
and Dr. the great Nikhil Pathak, and
Bhaskar.
everyone. Chetan, you are in India or in US?
I came back, sir.
Okay.
Everyone is asking the same thing.
No,
Where is Chetan?
नहीं निखिल वो क्या होता है? There are so many meetings I had to host, no? So
They are according to US time.
So no, according to US side, and it is very difficult to remember also there. It's totally time frame changes, no? So I had given it over to Manish. Manish was taking care.
So
Good
my guess
evening.
was right. Bhaskar sir lives
Our
in Italy.
foreign returned secretary is there.
And Bhaskar is not leaving also. Okay, चलो एक महीना secretary बाहर गया तो थोड़ा rest कर लेते. नहीं, he wants to continue. Even he was abroad. He continued.
Good evening, Dr. Banu, Nandita ma'am,
Good evening, sir.
Yes,
Good
yes.
evening, sir.
Nikhil.
So first time, this time Bhaskar has worked as a secretary for this Super 11.
I have experience of working, no, 2 years I worked. So that experience came in handy.
Correct.
So at least I could within no
No,
time.
that is right.
Good evening, sir. Dr. Bala, sir.
Yes, Bhaskar. Bhaskar, you
Hi,
are in
sir.
town. You are in Bangalore or elsewhere?
Bangalore.
Okay. Busy fellow.
Bala sir has a very nice background.
Yes.
After this, I will search for that only.
You go to his place, he is having the same library there.
Oh God. That's too much.
And it is apt for his caliber.
Correct.
Oh God. Oh God. I'm shivering.
Now you can.
I'm shivering.
Sir,
Agni Nakshatram, I'm still shivering.
Your nickname was a moving library. So now it is correct.
Library in the background.
I actually
No,
thought
library
it
is
was a
true
real
or not
background.
created.
It suits him.
Yeah, that's what I've heard about him and little bit interaction. I
Maybe
really
his own
thought that's his
publications.
library.
Only his own publications.
Even if you don't read, you should appear to read. It is said that, even if you don't do justice, you should appear to do justice. So I'm just keeping a library background just to cheat all of you.
We can start. 8:59.
Yeah, wait for a minute.
Why Nikhil is in hurry?
No, sir, not in a hurry.
He wants to get that background as early as possible.
So it should appear that I am studying. That is important.
That's the purpose. That's the purpose.
But for us, no, nobody would believe it, even if you keep it. Good evening, sir. Darur,
Good
sir.
evening, sir. Dararu, sir.
Good evening. Good evening.
Good evening,
Hello.
sir. Good evening.
Good evening. Good evening, Ranganath ji.
Good evening, sir. Good evening.
Good
Good evening.
evening, Dararu sir.
Now it's 9 o'clock. I think we started.
Dr. Sarkar has joined.
Yeah.
Yes,
He's
yes,
there.
yes. He's
Yes,
there.
sir. I'm here. Good evening.
He is all
He's there.
Pedicon background. Everything is Pedicon 26 for him.
Oh, okay.
Okay. Good evening, friends. On behalf of Pediatric Infectious Disease Academy, I, Dr. Chetan Trivedi, Secretary PIDA, welcome you all for another link of very wonderful, very successful webinar series, that is monthly webinar series, that is Super 11. Initially, as we all know, that it was a brainchild of Dr. Bala Subramaniam sir and rapidly been taken care of by our past chairperson, Dr. Darur sir. And so initially we thought only 11 episodes, but now it is Super 11 going for Super 22. So now this time, last time we had a wonderful case series by Dr. Mahesh Kore, and it was so many good feedbacks that we thought let us continue with the same pattern. And that's why now here we are just trying to concentrate more on a PICU cases. Of course, background will be PICU, but the crux will be our pediatric infectious diseases only. So this time we are going to decode the interesting cases of ID in PICU, and for that we have wonderful moderator. We all know that we have been impressed by Dr. Prabhas's collection of the cases, and at the same time we have very good panelists, Dr. Nikhil, Dr. Manu, Dr. Nandita, and Dr. Mihir Sarkar. So with this brief introduction, I would request Chairperson Dr. Bhaskar Shinoy to say a few words.
Good evening, all respected seniors, Dr. Bala Subramanian sir, Dr. Dararu Ranganatha, and Dr. Kundu sir, and all the other seniors. And It is very interesting session today, and very, I mean, like any other ICU case, it will be a complicated session also, and aptly led by Dr. Prabhas Prasun Giri, who is all of us know that he is a intensivist from Institute of Child Health, Kolkata, and ably these will be decoded by our panelists, Dr. Nikhil Patak, Dr. Nandita Ram, Ratnam, and then Manu Chaudhary, and then Dr. Mihir Sarkar. So with that discussion, probably today's discussion is going to be a wonderful one and learning points. We are eagerly waiting for the inputs from the learned panelists. Thank you so much.
So I think with that note, I think I will request Dr. Prabhas to start the session, and stage is all yours. Thank you.
Thank you, Chetan sir. Thank you, my seniors, Bhaskar sir, Bala sir, Kundu sir, and all other Dararu sir, and all our seniors. Today we'll go through a few interesting cases of pediatric infectious disease in the PICU. I am fortunate enough to have some learned panelists with me. I have Dr. Nandita R, who is MD in pediatrics and did her fellowship in pediatric critical care and now working as a consultant pediatric and pediatric intensive care in Manipal Hospital, Bangalore. I have Dr. Nikhil Pathak, who is also a pediatric intensivist and neonatologist, now working as a intensivist and neonatologist in Kamal Nayan Bajaj Hospital. I have Dr. Mihir Sarkar, is very close to me. He is the professor of pediatric and head of PICU unit of Medical College, Kolkata. And also distinguished faculty is Dr. Manu Chaudhary, who is a MD pediatrics and is a certified pediatric infectious disease specialist. So today we'll try to go through the journey of 10 different pediatric infectious disease cases, that real-time cases, no modification has been done, and we have encountered these cases in the pediatric intensive care unit of Institute of Child Health of Kolkata. Let us start with our session. Case 1. This 4-year-old boy, he is a known case of right maxillary rhabdomyosarcoma. He had been diagnosed on April of 2024 and completed chemotherapy with 12 cycles till December 24. So 8 months of chemotherapy with mainly vincristine, dactynomycin. He also received radiotherapy and went into remission in January 2025. But he started having low-grade fever and cough since January 3rd week of this year. Readmitted in
Kundu sir, please mute sir.
Readmitted in primary hospital after 2 weeks, being treated as community-acquired pneumonia with ceftriaxone and azithromycin for 7 days. But the fever was not subsided completely, but due to some reasons, they took the DAMA and went home. And after taking the DAMA from the primary cancer care hospital, he came us after 2 days. So he landed up to the A&E in our hospital in a very bad shape. He was tachypneic, saturation was 43% in a room here. He had been in compensated shock. The GCS was a bit down, E3, M4, V3. So this is the chest X-ray. My first question to Dr. Pathak, can you please describe the chest X-ray?
So, good evening, everyone. So, as you can see, clinically, the child is tachypneic and is hypoxic, and the X-ray is correlating with that. You have a bilateral shadows which are covering both the right and left side of the lung. More of the diffuse involvement, there is no collapse consolidation, and more of an interstitial pattern I would also say. On right side, I would suggest that there are some pneumatocoel or a small air-filled pocket areas which are there. So it looks like a very bad X-ray, and it is clinically correlating, and looks like a child has gone into an acute lung injury and requires a further PICU care.
Yeah, definitely. This X-ray in a single ward is almost bilateral whiteout lung, and possibly it will fulfill all the criteria of ARDS. So he had been immediately intubated and ventilated in our PICU because vitals were very bad. So after 1 hour, we got the blood reports as a total count was 14,600, neutrophilic, CRP 22 times. So my question to Dr. Mihir, that what is your diagnosis and how are you going to treat him?
Yes, thank you, Profas. So as Dr. Nikhil has already told us, this is a bilateral lung involvement with the all four quadrant with the both the air space and the interstitial space are involved. So it is a fitting in the ARDS like X-ray picture. And with this background of this patient with the post-chemotherapy patient with the history of fever and all the things that the infective etiology. So, and how we treat, yes, already the kit is ventilated and the ventilator is support that will have to be optimized. So I'm not going to the details because that will be the core PICU discussion. Regarding this antibiotic, yes, the patient already got the ceftriaxone and azithromycin, I think, outside. So and the patient is not responding here. So you have to cover the both broad spectrum antibiotic with the gram positive and gram negative, and possibly other like I will like to cover the antifungal here because it is a post-chemotherapy patient. So I will start with the meropenem vancomycin in this patient and start the voriconazole. And of course, I have to send the sample for the identification of further organisms. So there may be the other virus etiology along with it, or maybe the other atypical organisms.
Exactly. As the patient failed to respond completely with the first line agent and underlying immunodeficiency is there, the patient has been started with meropenem vancomycin and voriconazole. Bronchial valve lavage has been sent. On the bronchial valve lavage, the gram stain, culture sensitivity, CVNAT, BioFire all came out to be negative. It was not a surprise the BioFire came out to be negative. There was refractory hypoxemia with almost bilateral whiteout lung. We had to prune this kit and put on the child on high frequency oscillatory ventilations. Even the highest possibility setting of HFV, we are not able to maintain the saturation. So we have tried to shift the child to an ECMO center, but due to financial constraint, we are not able to shift this child. So this is a chest X-ray. You can see on the every day we are doing the chest X-ray. It's almost same on the highest possible HFV setting. The saturation is hovering around 82, 84, 85 like that. So my question to Dr. Chaudhary that what are the organisms we should suspect in these types of cases?
I think we started appropriately. We were thinking of community-acquired infection, did not respond. Then we start thinking of could it be viral with secondary bacterial? We see flu doing this to immunocompromised hosts, which are going to take a long time to get their immunity back and start behaving like a normal host. So they can get the pneumatoceles, like flu post and getting MRSA will get all these pneumatoceles. So you start thinking of that. But that should definitely in your BAL should show you on the gram stain or on your PCR panel. If you're not getting that, then we start thinking of atypicals, as rightfully you guys were thinking of fungal, which is high on the differential. We start thinking of TB, which again CBNAT was negative on BAL. It's a very good sample, should have come positive if it was TB. And then we again go into more atypicals like Legionella, Mycoplasma, should have been again got with our PCR. And then one of the infection that we usually think of with sudden deterioration of a patient is PCP in all these kids. And that's the reason a lot of these kids are on PCP prophylaxis, going home for pretty much lifelong or till their immunity get back. So those would be some of my differentials here for this patient.
Yeah, definitely. With the background of fungus, atypical bacteria, and you have to think about these things that I have already mentioned. But as the BioFire has came out to be negative and the BAL is a very good sample, so few of the things had been excluded. So when the BioFire came out to be negative, we have sent a specific PCR with a high suspicion of MINAT. It was a interstitial pneumonia. We have sent a specific monoplex PCR of pneumocystis jirovecii, and it came out to be positive. So what should be the next course of action, Dr. Nandita?
So good evening. Thank you, Dr. Prabhas. So as we have been discussing, this is a quite immunocompromised child, and suspicion of PCP is very good because since we have got every other report coming negative. So at this point, we'll have to rationalize and probably start the child on Septrin. IV preferably, trimethoprim around 20 mg per kg per day has to be started at this point. If we are struggling too much with hypoxia, maybe from ICU point, we may have to consider steroids to help the child ventilate better.
Yes.
I think with PCP, you with severe condition, you have to give steroids. You have, over taper
Yeah.
3 weeks. But you
Yes.
definitely need steroid for this case.
Yes, yes.
So in this case, we have not used steroids. We have just given a cotrimoxazole, and we have thought that possibly let's give cotrimoxazole for 24 to 48 hours. If not responding, we can add steroids. But surprisingly, just after getting 2 doses of cotrimoxazole, the IV cotrimoxazole, the patient responded dramatically, and we can see the
Yes.
clearing of the X-ray. The bottom X-ray is just the starting of cotrimoxazole. It is after 48 hours, and this is after extubations. So shift back to conventional mechanical ventilations after 2 days of starting IV cotrimoxazole. He had been extubated after 4 days and discharged after 14 days is the time of discharge. But still during the time of discharge, he needs a bit of oxygen, 0.5 liter per minute. But thing is that to our utter surprise that though he suffered from a hypoxia for a prolonged period of time, even on post-discharge, we have made a small celebrations for one PICU day. He was doing well. Very good, very good. This is the what we want, that you don't only want to make the child survive, but we want the intact survival. So my learning point is that pneumocystis jirovecii typically presents with interstitial pneumonia. Empirical therapy with cotrimoxazole is life-saving in any immunocompromised patients with interstitial pneumonia. So I want the opinion of Dr. Manu that if any of these types of patients, those who actually should be on cotrimoxazole prophylaxis but was not taking cotrimoxazole prophylaxis, come in a bad shape, should we start empirical cotrimoxazole therapy or we should wait for the PCR to come? Because a PCR for pneumocystis jirovecii is not always already readily available.
Yeah, the other wonderful thing you can do is you can send GMS stain, and most of the microbiologists have it. And they are so experienced because some of our microbiologists are of the era when we used to have HIV with PCP. So they
Yes.
are able to pick up that the cyst with
We
the
heard from-
lymphozoites. So that's one thing I would suggest when you are suspecting your patient is not behaving. And definitely we have to, if kid is my goal always is, I know as an ID, I say save the child. You can start broad, but rationalize. You should know when your endpoints are for those things. So as long as you know what you're treating, what you're thinking of, it sounds reasonable, please go ahead. The other thing I was thinking is, a lot of CT is a very good, sometimes CT is also very helpful to tell us. There's a lot of ground grassing, and some of these expert radiologists will also tell you, hey, are you thinking about PCP at this time? So even that can, that was the other point I had in mind to share with everybody. But yeah, probably we should.
Thank you. So coming to our next case. This is the case of juvenile dermatomyositis with a systemic capillary leak syndrome. I'm not going into the details of the symptoms because it's a very rare complications of a juvenile dermatomyositis. She had been intubated total 3 times in a 4 weeks of period. It's a prolonged ICU stay. Initially, she had been intubated due to capillary leak, fluid overload, and respiratory paralysis due to JDM, followed by VAP and sepsis. There was 2 failed extubation trials and extubated third time on day. Extubated on third time on day 27 of PICU admissions. Had underwent CRRT for 2 weeks, followed by SLED due to AKI and rhabdomyolysis. Our CPK was 78,000, sky high. He went to all the invasive monitoring, lots of plastics in the body. We had to immunosuppress her with pulse methylprednisolone 30 milligram per kg for 3 doses, followed by pulse IV cyclophosphamide. She got also multiple broad spectrum antibiotic during the stay of 27 days. This is the patient when she was quite sick on CRRT and mechanical ventilations. For as there was a myoglobin with AKI, we had to do a CRRT filter has changed to auxiliaries for myoglobin removal. Her sensorium was acceptable till 4th week. On 5th week, again, new spike of temperature with altered sensorium had been started. Before that, all the times when you were intubating, extubating, her sensorium was normal. So she had to be intubated due to poor sensorium for the first time, this time. There had been acute deterioration of sensorium over the past 2 days. So my question to Dr. Nandita, that with this background, what may be the possible cause and what will be the plan? This time the girl has been intubated due to poor sensorium only.
So this is a child with probably a lot of multi-system involvement, has prolonged ICU stay, and is on multiple tubes and antibiotics. At this point, we still want to rule out sepsis, whether it is some kind of neuroinfection, meningitis, or encephalitis. Considering the background history, we'll have to look at fungal, viral, bacterial, same like as we discussed the previous case, some atypical situation can also be there. Also, she is on steroids, cyclophosphamide with a kidney injury. I don't know her blood pressure at this point. I may want to rule out press also in this situation. And if there is some other vasculitis that is going on, is my other concern at this point. We would probably want to get an MRI little urgent, and based on our hematological parameters, probably CSF is what at this point thought process
Yes.
with
So
repeating
definitely this,
workup.
with the background of this immunological disorders, rheumatological disorders with lots of antibiotic immunosuppressors, there are two possibilities that maybe this immunological disorders has involved the brain, like in lupus, where the CNS lupus that involve the brain, but brain CNS involvement in JDM is extremely rare. The blood pressures may be due to on the higher side, there may be a press or vasculitis, but the thing is that there may be a secondary sepsis that the kid had been immunosuppressed and lots of things that we have done. So we have done an MRI brain. MRI brain revealed that multiple rounded, thick walled, few are the small and few are larger walled peripherally enhancing lesions. And MRI NGO came out to be normal. And these are the granulomatous lesions that were in the brain. There are multiple lesions. I have just taken a picture of two prominent one. So, Dr. Manu, what should be the differential diagnosis at this moment?
Very remarkable, MRI. So she got cyclophosphamide, she got methylbred. So her T cells are pretty much knocked off. So then you start thinking of what are the infections which we would see in these kind of cases. And first thing that, as Doctor said, it is fungal that comes to your head. And these lesions are quite thick-walled. It is brain abscess, basically multiple brain abscesses. Bacterial, atypical bacterial can also be there. Yes, TB can get reactivated, T cells are gone. Cryptococcus lesions are not very, this doesn't look like cryptococcal. They're very, your radiologist will tell you. But fungal is definitely high on. The other differential I would have toxo, but again, MRI will be very helpful to give you your, some kind of lead that it's probably, this looks more probably like fungal than toxo or crypto or TB.
So there are multiple possibilities, maybe CNS tuberculosis, multiple brain abscess, and some fungal balls inside the brain. So the MRI was not able to differentiate that what is it. We have done the MR spectroscopy. It was definitely not suggestive of NCS and tuberculosis, but something pyogenic was there. So Dr. Pathak, so what should be our next action at this moment of time?
So initially, what we have our differentials. So we are thinking of a brain abscess. The most important, the child has been such a long period in the ICU with multiple interventions, with everything which is going on, PIRTs, multiple intubations. So whatever organism is there, it is a blood-borne organism. So it has reached the brain with the immunosuppression, it has gone into an abscess formation. So what my important thing would be, whatever samples I can get for the CNS would be important. So if it would have been a superficially located abscess, direct brain may have been helpful. But here you can see which is not possible. These are deep-seated abscesses, and even the MRI is not giving you any clear-cut picture about the organism. So what is the next thing we can get is we can get a CSF sample. So what we can do is we can do a guarded CSF. This is important. It should not be a simple CSF. It should be a guarded CSF. And we should send a complete panel of immunosuppressive drugs, immunosuppressive organisms, which we were thinking. So if you see the list, we will send it for all the organisms, the PCR test for all the organisms, a routine microscopy, a gram stain, look for AFB, even though the spectroscopy has not shown to be AFB. We can look for CBNAT or a PCR in the CSF. And the most important would be our CSF biofire panel. And it should include other differentials of fungal. It should be. So one more thing I would like to add, that whenever you are treating such immunosuppressed patient, your PCR which you are choosing, there are multiple panels. So whenever you are choosing your PCR, it should be appropriate. So if your differentials has an histoplasma or an aspergillus or cryptococcus, make sure that your PCR panel has it. So my preference would be to get all these things with a CSF. So that would be the closest thing which is there to the brain, and try to get to a specific diagnosis which will help me in the treatment.
Exactly. So what we have done a lumbar puncture CSF analysis. Is told 2 cells, glucose and protein was normal. CSF gene expressed was negative. CSF biofire was negative. but CSF for Aspergillus fumigatus was positive. We have sent a fungal panel for PCR. This is different types of PCR. And it came out to be that Cryptococcus was negative, histoplasmosis was negative, and Aspergillus fumigatus was positive. After 2 days, there is further deterioration on lung wise. There are again development of the ARDS at the moment of time. We have sent a fungal PCR to the bronchial blood lavage, and the bronchial blood lavage also revealed this is a Aspergillus fumigatus. So actually infected the brain first, followed by the lungs. So this is nothing but a case of CNS aspergillosis as well as the pulmonary aspergillosis, invasive pulmonary aspergillosis. So the diagnosis of CNS aspergillosis has been made. Previously, CD was received IV caspofungin intermittently as empirical therapy for two times or 2 occasions for 3 to 4 days, but the culture never flagged for any fungus element until now. So now, what should be the antifungal of choice, and how many days would you prefer to give it, and how to monitor the therapy? Dr. Chaudhary.
Yeah, so IDSC guidelines about aspergillosis, it's for adults, but we usually collate from adults only, are inferences. So voriconazole is your drug of choice for this patient. IV versus oral is based on how the child is improving, how the gut absorption is, oral intake possibility. So anywhere transition from 2 to 3 weeks to the oral aspect. Now, duration is going to depend on how the patient is improving, and your imaging is going to help you, and it also depends on the kind of immunosuppression this kid is going to be on. So it can vary anywhere from 6 weeks to 12 weeks to even months based on like the overall picture of the patient. And when the kid is so sick, we do, we have this tug of war with our colleagues who are managing their underlying disease to if they could bring down the dosing of immunosuppression so that at least we are ahead of the infection. Some of these cases, if the abscess is very big or peripheral, there could be a surgical intervention that might be needed. Also, we should be aware that they can get complicated. So they can develop hydrocephalus, they can have other complications in these patients. We also, all these kids, I usually end up definitely getting a ophthalmic evaluation done, because you have to see, how we say, eye is the first door to your brain. So sometimes even that gives us hint, as well as it tells us how much involvement is there in the body and where all the fungus is impacting the patient. So you have to get
screen for fungus all over the body, fungal ball in the kidneys.
ultrasound of the abdomen, echo of the heart. Like you have to, because that will also determine how long you're treating this patient.
Subsequently, this girl developed also fungal keratitis also.
Yeah. And the last point I want to make is about therapeutic drug monitoring. If it's available, please get it done for your voriconazole, your azole levels, because you'll be amazed how good some of these kids are with acylating these agents. So, you might not get therapeutic levels. So you're just, from the basic, you might have to really double or triple your dosing to get the best impact for this patient. Also, it's an expensive drug, so we have to be very cautious how we are using it and how we are helping them to procure it. Yeah, those are some of the points I would like to make.
End point is very difficult to determine here. We cannot say that there will be an MRI cleaning. So the thing is, the child may improve symptomatically, but the MRI changes we may not get. They may have a cavitatory lesion, and
so even after 4 weeks of IV voriconazole, we have repeated the MRI, but it was not that much improving.
So I was very interested. So one more thing is, when you are treating such a sick kid, I would prefer a dual therapy, a voriconazole plus a capsofungin, even though the child has received it previously, because it's a disseminated aspergillosis. So you have already told that you got a keratitis also. The guidelines say that when there is a dissemination of aspergillosis, 2-drug therapy would be more helpful than using a single voriconazole.
Yeah, it depends on how immunocompromised your host is.
So that
are you going into like salvage therapy? So if you're going into that way, yes. But please don't combine amphotericin with azoles, because they have antagonists. But there are definitely evidence in AML patients where we are into salvage therapy using echinocandins with the azoles.
So what you have done in
one thing is that if the PCR is not available and culture is not going, so what will be the role of galactomannan here?
Yeah, so you have done this. So actually, before starting the IV voriconazole, we have done the baseline galactomannan. The galactomannan antigen index was 3.2, and we have quite confused that how many days we need to continue the IV therapy, because it depends upon the patient's conditions. The patients received immunosuppression for the first 3 to 4 days, then almost 2 months she was on intermittent stress dose of hydrocortisone. No persistent immunosuppression was going on. So we have monitored the therapy during the regarding the few articles that with the galactomannan antigen index.
Yes.
The baseline galactomannan antigen index was 3.2. After 4 weeks of therapy, it came out to be 0.7. And after 6 weeks of therapy, it came out to be 0.26. So if the galactomannan antigen index is more than 1, or few of say more than 1.5, that means replicating active fungal aspergillosis is there. But if it's coming below 1 or preferably below 0.5, then it's not there. Even the lesions may be there, but active fungal replication is not there. So after 6 weeks, after 4 weeks, it came out to be 0.7. But to be more sure, we have continued for another 2 weeks, and after 6 weeks, came out to be 0.26. And she was taken off the voriconazole because PCR may be positive even after the fungus dies. So this is the condition of the kid till now. We are still fighting for this kid. That's why we just shifted from IV voriconazole to oral voriconazole. But now the primary disease is taking upper end. She is developing repeated capillary leak-like symptoms when giving IVIG. Again, something is going on. In this case, very difficult. If you are treating the primary disease with immunosuppressants, the sepsis will cripple her down. When you are treating the sepsis, the primary disease is increasing. We are still fighting with this kid in our ICU.
Just one point, can I add,
Yeah.
sir? One thing we have started doing is, and I know we'll be talking about some of these cases, whenever we have a patient who's really immunocompromised and is needing broad spectrum antibiotics, we are putting them on prophylaxis for antifungals.
So
That's
prophylactic
one thing we are changing now in our practice. And then the second thing, just on the biomarkers, from ID standpoint, literally I have stopped using it. Like, it's so much based on clinical, and you know how imaging and everything is panning out. Even if you don't get these biomarkers and your patient is behaving as you had expected, you will still reach that data point which you want with this. Just
So I
One
think
thing-
6 to 8 weeks should be the minimum thing,
One
even if
thing
you are
that-
not monitoring the
One thing that
galactomannan thing.
made us surprised that in ICU, usually we get a secondary fungal as candida. It's maybe a candida albicans, non-albicans candida. Lots of time we're getting, but we never get aspergillosis. We're quite surprised why the kid developed hospital-acquired aspergillosis. Then we started the literature. We found out that if any new construction is going on, there are chances of getting aspergillosis. And unfortunately, there had been our new building has been constructed just adjacent to our PICU, and few of the opening parts are there. So that
I
make
don't
us-
think, sir, I don't think you can blame it as HI, really. If you're so immunocompromised, if your T cells are knocked off, you can get fungal septate, aseptate infections. And we saw that post-COVID also, right? So
Yes,
there were
yes.
a lot of aspergillosis, mucormycosis. So I don't think it's HI. It's probably just the host.
Yes.
Our host is at risk.
Okay, but we went through few literatures. Those were saying that there are few outbreaks of secondary aspergillosis in ICUs whenever they linked it that there are nearby construction was going on. That's why there was increase in the secondary aspergillosis. So my take point from this that CNS aspergillosis, though rare, can present with granulomatous vein enhancing lesions in the brain. Immunocompromised host with history of construction nearby the host residence, coupled with granulomatous ring enhancing lesions in brain, is highly suggestive of CNS aspergilloma, though very rare in pediatric populations. So case 3, this is a 7-year-old girl with SLE. She presented with cough for 3 weeks and fever for 2 weeks. She failed to respond to ceftriaxones, followed by IV vancomycin and meropenem. Total antibiotic was given for 11 days. Then she came to us. So what are the next investigations you want to do, Mehta?
Yes, so you can see the X-ray of this patient. So there is the collection, this is the insisted collection over there. And I'm not sure, it may be abscess also, but that is not very clear from the X-ray. but there definitely there is some collection, and it is with the interlobar fissure. So we have to, in the bedside, USG is there. I will definitely go for USG. So if there is some collection in this space, and definitely if it is not, or if it is not definite from the ultrasound, then the CT scan will be help you out to rule out any encysted collection or any abscess formation is there. And also you have to send the sample, whatever sample you can get, send for the culture of this patient and the bacteriological or the vital diagnosis. So if it is availability or the USG guided aspiration, or it may be the induced sputum. So this patient is not ventilated, so you have to be rely on the induced sputum or the sample from this collection. So this will be the investigation at the present moment to do according to other investigations related to the SLE and the other management you want to do. You have to do it.
So completely agree. So we have sent a sputum and CCT, and the CCT clearly denotes a lung abscess. You can see there's a lung abscess. So what should be the antibiotic of choice in this case, Dr. Manu?
I think these are very reasonable choice. Vanco and meropenem is, very good choice to begin with when they are not responding to your first line, because you cover most of the lung abscess bacteria in this. My goal, more than keep going up on the antibiotics, would be finding out what's causing this. It's a huge abscess. Your antibiotics are not reaching it. We need to find out. It would be both diagnostic and therapeutic management of this collection.
Okay, so as the it was not responding to even a meropenem vancomycin for 7 days, running high spikes of temperature, CRP was not coming down. So with a wild thought, we have added clindamycins and some empirical therapy with the voriconazole, keeping in the mind of immunosuppressions. So patients was being symptomatic even after 7 days of IV clindamycin and voriconazole. So it's almost 8 days, 9 days of hospital admissions. So what else can be done to isolate the organism, Dr. Nandita?
So it's been about 7 days. So we really have to work hard and try to get some tissue sample, So ultrasound is a favorite gadget in the ICU. So we would go ahead and try at least getting some tapping, ultrasound guided, abscess drainage, whether therapeutic or we'll have to go ahead and drain it.
Okay.
And sample.
So before going to ultrasound guided drainage, we have performed a bronchoscopic lavage, and it came out to be negative. Even the lower respiratory biofilm also came out to be negative. So with a bit cautious, we have done ultrasound guided drainage. You can see the lung abscess. Put a needle, take out some parts, and send a ground stain culture and sensitivity. And when our microbiologist, after a few hours, I got a panic call from our microbiologist, and he told that he can see some atypical things in the ground stain. And then he himself took the photograph and sent it to me to WhatsApp and asked me, "What do you think? What is this is there?" So definitely, I was not able to answer. So Dr. Nikhil.
So it's a very rare case. I have seen only one case, and that too has been presented to me with a diagnosis. So I have not personally seen these cases, but you can see these are gram-positive cocci. You can see there is a branched thing. There is various branching. These are like, you can say, a gram-positive cocci with filamentous rods, and it points towards nocardia. So even if you see one of your earlier slides, so what we were suspecting, that any child with an immunosuppression, always keep in mind when you are thinking that your routine BALs are coming negative, always think that there is some abnormal organism which is there. What I would have preferred is to get this as early as possible. One thing also we need to, because if you see the case properly, it's a SLE with a fever and cough for 2 to 3 weeks. Also keep in mind that your primary disease is also active, and it can keep the fever and cough which is there. So you have to treat both the things. And we have seen multiple cases of SLE who may present with the pulmonary symptoms, and they may have completely things negative. So you may have all BALs negative, culture negatives and everything. Luckily, you have got nocardia positive, so you have something to treat. And it's a
sometimes it's difficult to diagnose between the SLE flares or infections, but there are two very good pointers is that in usually SLE flares, the complements will be down and CRP is
Yes.
usually negative and ESR is usually high. But when it's complicated by secondary infections, your complements may be normal, your CRP is usually high as well as ESRs are usually high.
We were not getting any organisms, so
Yes.
that's why I'm saying that you should keep that in mind. But you have now one, so you should do.
So, what are the further tests that you want to prove? Because beyond these things, our microbiology labs was not able to process beyond this. So, on the basis, on just on the gram stain. So, what are the further tests to prove it, Dr. Manu?
So I think nocardia is quite typical. I don't think you need more. You definitely have to rule out actino, which basically they do a simple acid fast stain, which this is modified acid fast, which nocardia will be positive and that will be negative. And if you have nocardia, then you please target managing, taking care of that infection.
So the differentiating point from the actinomycetes is basically due to a modified acid fast stain that's been done in some other centers. Nocardia specific culture is not usually done, but after the advent of Melditov, this is a very sophisticated testing has been done. So this atypical organism can be identified as early. So what should be the
Melditov can be done only once your culture grows.
yes,
So
yes,
Culture growth.
the culture growth, only the
the
culture.
second new thing that has come up is it's called something called next genomic sequencing. It's a
Next genomic sequencing.
DNA typing of the organism. They look at the RNA or 16S RNA of the bacteria and is able to identify. And in that, any sample can be given. You don't have to wait for the cultures. And
Yes.
this is something new that has come up. So we are still learning about it, but that's something we can offer. If
We are doing few cases in tuberculosis as well, that genome sequencing.
Yeah.
So what about the treatment?
Yeah, I think you flashed the next table, but very standard. This is a severe case of pulmonary isolated. I think we'll have to give IV Bactrim with amikacin, and then eventually we can switch to oral. The course is long, anywhere from 3 to 6 months if it's just isolated issue, cutaneous issue, but it can go as long as 12 months, especially in this kid. She might need this oral for a very long time. The other point I would say in management is I would check this kid for immunodeficiency. Some of these lupus kids have CGD as well, part of their whole program.
There always.
So that's another point I would make.
Yes. Okay. We have
Surprisingly, the child was on meropenem and still has not responded.
yes.
So it's the
It
same
didn't
group.
respond because we didn't address there's a source, right? So there are three
Yeah.
things you have to worry about: the host, the source, and the management. So I think management might be okay, but if you're not, it's such a big abscess, right? Your antibiotics are
You
not
have to
Yes, we have
go
brain
in with
abscess as well.
If it's a loculated
Yeah, so
abscess,
address the
I think
source.
penetration would be quite poor too. Yeah.
So we have treated this girl with IV cotrimoxazole and amikacin for 6 weeks, followed by oral cotrimoxazole for another 3 months, and the girl did well after that. So learning point is that if any immunocompromised patient present with lung abscess, nocardia should not be the first diagnosis, but should be kept in the mind. Okay. And
one
here
more learning point. Ceftriaxone is also a very good drug. You have saved 2 patients with that.
Yes. Ceftriaxone is lifesaver in ICUs nowadays, actually. And one thing is that you cannot neglect the basic test like a simple ground stain in the advent of the sophisticated tests like biofire or other things. This diagnosis has been made only by a single ground stain, actually. Okay, coming to the case 4, this 11-year-old girl with acute encephalitic syndrome, intubated and ventilated due to poor sensorium, no oxygenation or ventilation issue, extubated on day 4, desaturated again on day 5, re-intubated. Initially, the lungs was normal, clear. This is the post-intubation X-ray. You can see the bilateral patchy hepatitis was there. So my question to Mihirda, what happened to this girl and what should be the next step of management?
Yeah, so the child was admitted for the acute encephalitis syndrome and the lung was normal. And now you can see there is a increased respiratory distress, oxygen requirement, and the ventilation requirement. And X-ray, you can see this is the bilateral, almost white out lung. So all four quadrants are involved. So this is basically a ventilator-associated pneumonia, and the child was intubated. So it is the complication of the patient having the hospital-acquired infection. So next step, yes, already you have taken care of the respiratory support of this patient. Then antibiotic, of course, it depends upon your hospital antibiogram. So this kid is already admitted in your under care. So in my unit specifically, it will be like this colistin or polymyxin and with the tigecycline, the next step that we use. But yes, it depends upon your hospital antibiotic biogram you have to choose. And of course, the other blood investigations, like you have mentioned, the CBC, CRP, and also the other organ function tests like the LFT and what is the creatinine, urea creatinine that you, because the hemodynamics, this the pharmacodynamics and the pharmacokinetics will depend upon the other organ dysfunction at the present and moment, because the patient having the other issues as well.
Yes. So during depending on our ICU policies, now the policy has been changed for the last 1 year. I think this case is 1 year old case. That is moment of time. Usually we upgraded the antibiotics to meropenem, tigecycline, and colistin, and it had been done as well in the adequate time. There's definitely no confusion about the diagnosis. This is a ventilator-associated pneumonia. So there is no improvement in the respiratory status in the next 48 hours. So what may be our possibilities, Dr. Pathak?
So now important thing is now there is no improvement, and you have already tried to cover it with a very broad spectrum. So you have got gram negative, you have broad spectrum, meropenem is there, and also you have given a good staff cover. So one of few things now, why is not responding? So either the organism is resistant, or there is an atypical organism, or it's any fungal element is there, or again there may be a viral issues are there. So it's a viral pneumonia, and so it's not responding. Again, important is as much as culture. What we do is as soon as the child is intubated, the first intubation we try to take a bath. So that gives you a very good
There
idea.
is the Bell report. This is a pan-drug resistant Klebsiella pneumoniae. So at this moment of time, our laboratory was not doing routine Klebsiella infectum and Astronym's testing. When we requested or when they get all the things are resistant, they did it. So you can see this is the first case of this type of Klebsiella that we have seen in our eyes. It is almost 2 years back. It's the Klebsiella pneumoniae that is pan-drug resistance, also resistant to Klebsiella infectum and resistant to Astronym. So, Dr. Manu, what should be the antibiotic choice in this case? This is the pan-drug resistant.
Really unfortunate. You know, you'll be shocked, and Dr. Chetan can back me up. It was in Ahmedabad. I had just moved back from US, and we had a neonatal case with pan-resistant Klebsiella. And I was like, oh my God, what do we use for this kid? No, just one concept I wanted people to understand is when you end up with a pan-drug resistant organism, you will have to do combination of medications, you know. So we've used chloramphenicol, we have used levo, poly B, so 3-4 antibiotics, high levels, targeting different mechanisms of resistance, and maybe somewhere can help us get a positive output on the patient. So I see you've written Ceftaz AV and Astronam individually resistant, but what really works with this combination is the AV bactam with Astronam that works together. And there used to be e-strips to check those. I'm not using it. We have come to know that NDMs in India, fortunately, so far are susceptible to this combination. And unfortunately, we don't have just AV bactam with Astronam, so we end up using this combination for some of these organisms. And we are looking, there is something called CARBA-R expert test, gene resistance expert test. So if it shows you NDM or VIM or OXA48 with NDM, then we are more confident that this combination will work. Now, this combination is not going to work for your Acinetobacter, and which is one of the high, you know, like it's one of the organism we see in our ICU. So we have to understand, like, oh, great, this is the last drug, we have something, but it is not going to work for your Acineto. So one of our pan-resistant Acineto, we end up using Eloris, the ceftriaxone.
Sometimes we already also give the very high dose of sulbactam, isolated sulbactam.
Yes. So isolated sulbactam with some
All
of
these
these
things.
combinations. So that's something we have used in the past. But this
One-
hopefully this avibactam with astronam would target
So,
this.
so even if your culture is showing it is resistant to separately as ceftazidime, avibactam, and aztreonam, the combination of ceftazidime, avibactam, aztreonam actually works. Here, actually, the combination of avibactam and aztreonam have to work. That in our
One
hospital,
thing, one
yes.
thing you have to keep in mind that we have to start it simultaneously
Yes,
and
yes,
the
yes.
infusion.
You have to give the infusion simultaneously at the same time. You have to give the infusions. So, the trial of avibactam aztreonam combination is going on in our hospital. This trial is going on. Possibly, it will be marketed by Pfizer within next couple of years.
That's
So,
wonderful.
Few
there are
companies have sorry.
Yes,
A
so-
few companies have individual avibactam and azithromycin individually. So we have, and what we should think is the other drugs. So adding a high dose of sulbactam, like she said, the EDTA, so that may also help.
So in this case, you have started on ceftazidime, avibactam, aztreonam, and gradual improvement in 3 days and extubated. So the bottom line is that ceftazidime, avibactam plus aztreonam, there is a synergistic combination tested against carbapenem-resistant enterobacteriaceae, characterized by phenotypically or genotypically. So basically, this is totally specific for Klebsiella pneumoniae, but this is not effective against Acinetobacter and sometimes not effective against Pseudomonas or E. coli. So the learning point is that in the absence of availability of cefiderocol, the ceftazidime, avibactam, aztreonam is the last resort of antibiotic against XDR, PDR, Klebsiella pneumoniae. The synergism is almost always sensitive against PDR clade, even if both showing resistant. Actually, the avibactam and aztreonam part is working, and the aztreonam avibactam combination trials are ongoing to combat both the oxafortiwate and NDM.
I would just add one more thing here about Bactrim. Some of these VAPs which do not respond to your good colistin, poly B, or these combinations, you start thinking of steno and Burkholderia because
Yeah,
that's
yeah,
the
definitely.
mechanisms we see, and
That's
then
why
Bactrim
regularly is now 3 patients are having steno and Burkholderia, and it's very difficult to eradicate them. Repeated cultures, you are saying you're coming up positive.
So you can think of that also when.
Yes. So just halfway round, case number 5, we have to be a bit rapid. So this 10-year-old girl present with a fever and cough for 8 days, respiratory distress for 3 days, treated outside with oral coamoxicillin azithromycins, and then admitted in outside hospital, got IV meropenem for 2 days, not responded, came to us in our hospital. The chest X-ray on admission in our hospital, the total count was high, hemoglobin was low, CRP was sky high, there was transaminitis. So airway was maintainable. She was tachypneic with saturation of 86%. In the room air, there was cold peripheries, normotensive, improved with fluid boluses. GCS was 15/15. So my question to Dr. Pathak. So what is the diagnosis? What the
So it's a
antibiotic? What's the investigations and what the support you want to give?
So again, it's a community-acquired pneumonia. The child has already received multiple antibiotics outside. So what organisms which we are thinking? So it's a non-responding organism. Most probably at 10 years, what we need to think is streptococcus. The child has progressed, so staphylococcus or PVL staphylococcus may also be there. The second thing is, so these are the organism, and an adolescent presenting with such a huge patch, and clinically if you see the child is not so in distress and is hypoxic but not so in distress, so that may point towards a mycoplasma or an atypical organism. So if you go back, so what I will do is I will investigate the child completely, CBC, CRP, LFT, blood culture, USG test to look out if there is any collection or is there any complication of empyema or anything, and try to get any cultures that positive. So important would be a bowel culture if it is positive, or a blood culture, and try to get, and all the respiratory support she needs. So high flow, whatever she needs.
So Dr. Nandita, my question is that what is the policy in your unit that if this school-going adolescent girl or 8 or 10-year-old girl presenting with a solid lower consolidation, should we continue only with ceftriaxone or you want to give some mycoplasma coverage? And what should be the drug for mycoplasma in these types of cases?
So we did have a bout of mycoplasma the last few months, probably early beginning of the year. Yes. So Azi did work oral azithromycin, and if you are suspecting, probably get a PCR, and that will also help you to get to the diagnosis too.
Okay. This girl already got oral azithromycin OPD basis. So there was a rapid.
So we did come across resistant cases too. So if we still are high, mycoplasma is high on CORDS, we can consider doxycycline. And of course, sometimes steroids also help in the situation.
So there's a rapid deterioration over the hours, more tachypnea and desaturations, altered sensorium, decreased urine output. There was a blood mix loose stool, further drop of hemoglobin to 6 gram percent. He was been intubated and ventilated. A central venous line has been done. The X-ray, right side, almost whiteout lung. So, Dr. Sarkar, do you want to change your antibiotic, Medha?
Yeah, so you can see that the patient is deteriorating, and there is the features of the DIC with the AKI and the encephalopathy. So the child is going to have a multi-organ involvement here, and the patient is on ceftriaxone only here. So I want to add along with this vancomycin or the gram-positive coverage. There's a solid, there's a pneumonia is there, so the staph coverage should be there. And yes, the azithromycin, the doxycycline I would start, because already you have discussed the mycoplasma is a big possibility. But studies have shown that the 50% of the mycoplasma is in the Taiwan study has shown that they are resistant to azithromycin. So the patient who are going to the ICU and the very sick patient, we start the doxycycline instead of the azithromycin. And of course, the other supportive treatment you have to start with this patient and send the every possible sample to get the bug, identify the organism. And the steroid, of course, that we have already identified, the steroid will be helpful because mycoplasma with the multi-organ involvement, steroid will be helpful.
So this is the case when we just started getting the severe mycoplasma cases in the last epidemic. So the concept of steroid was not that but clear to intensivist, because being an intensivist, we always fear to give steroids. In this sick kids who is intubated, ventilated, multiple lines, we are on hypotensive, multiple inotropes, we put the child on CKRT, lots of bleeding, progressive deteriorations. The girl has some 8 multiple lesions, and definitely we have done a bile, and a bile revealed biopha revealed mycoplasma. But we are quite sure that okay, this is a bile. We have seen got the mycoplasma. The child got azithromycins. We are getting lots of reports from Taiwan, China, azithromycin resistance. There is no report from India. We have given doxycycline very early, but the girl sets in on wards. She was not responding properly. This is the early phase of epidemic when it started getting severe mycoplasma cases. So why she is not responding? Is our antibiotic choice is wrong, or you need to do something else, Dr. Manu?
We kind of discussed it, right? So when we started seeing these kids with very typical mycoplasma, not even getting PCR positive, but the whole story fits mycoplasma so well. We actually started, there's an infectious diseases group of doctors across India. We started posting, hey, are you seeing this? Are you seeing this? And then that's when we switched to the practice of doxy. And if they were going into ICU with multi-organ involvement, how Dr. Sakai is saying, we started doing steroids as well. So I think it's not just the infection. I think it's the infection triggering the inflammation and the whole cytokine issues that needs to be addressed.
There are lots of immune-mediated phenomena are going on in mycoplasma. So after adding steroid, we can see there's a gradual improvement. There's a pleural effusion was there. We have put a chest drain, developed pneumothorax, and ultimately the girl improved and went home with a intact neurological things. So we got lots of reports that coming out that mycoplasma resistance to macrolides, and doxycycline as well as levofloxacin is a very good drug. So then about the steroids, so this those Chinese article, there's a very good article on steroids, as well as the Fiji textbook of pediatric infectious disease. They are telling that if your mycoplasma is very sick and if the multi-organ involvement means more than a lung and ICU, you should start steroid according with doxycycline or levofloxacin. Or it is a single organ disease, only lung, but fail to respond to doxycycline or levofloxacin in 48 hours, you should start steroid. Not all the cases of mycoplasma needing steroid. There is a doubt between the doses of steroids. The Fijian is telling is going to be a low dose of steroid. This Chinese study, they are showing that most of the patients are intensivists are a bit comfortable to give a low dose of steroid, like 1 to 5 milligram per kg. A few of them gives a pulse steroid, but pulse steroid causes total immunosuppression. If these things associated with some autoimmune hemolytic anemia like picture like our cases, then the role of IVIG is also there. So, but bit costly, but few of them also given IVIG, but definitely we need to give steroid. Possibly the low dose steroid is effective in most of the cases until and unless you are facing a extreme hyperphosphatemia sepsis with FANG macrophage activations. So learning point is that for severe mycoplasma infections, either doxycycline or levofloxacin should be used as a drug of choice in view of growing concern of azithromycin resistant. That does not mean that each and every cases of suspected mycoplasma or proven mycoplasma, we should use doxycycline or levofloxacin. Outpatient-wise, azithromycin is still a good drug. We have treated lots of mycoplasma with azithromycin as well. And life-threatening mycoplasma with MODS or mycoplasma with a single organ disease, not responding within 48 hours, almost always needs salvage immunotherapy in the form of steroids plus minus IVIG. So case 6, this is a 4-year-old girl, dengue fever with a capillary leak with compensated shock, managed with IV fluid boluses as per protocol, stabilized, but fever persisted beyond day 8. On day 8 of illness, she developed a fever spike of 106.8 degree Fahrenheit, followed by GTCS and altered sensorium. Intubated, ventilated, loaded with AEDs, refractory status epilepticus. Investigation during the time, lowest platelets was 42K, highest was now was 98,000. So platelet is improving, capillary leak is improving, transaminase is improving, ferritin initially was high. We have not given anything, any immunotherapy. Now is improving, and there is a mild coagulopathy. Iron was just 1.5 like that. So what happened to this case, and what further investigations you want to do, Dr. Nandita?
So this is a child with dengue. Probably we are dealing with day 8. So dengue neuromanifestation can happen from day 1 to thereafter anytime. So I would still suspect probably dengue encephalitis or encephalopathy. Also, we did come across situations where we had acute demyelinating encephalomyelitis to edem. That is another possibility, or hemorrhagic necrosis. So I would probably do the neuroprotection, control the fever part, and start thinking of MRI at the earliest. And since platelets are also improving, maybe if the child is stable and there is no raised ICP clinically or by imaging finding, a CSF analysis would be a option too at this point.
Perfect, totally agreed. So dengue fever with a day 8 of fever, hyperpyrexia, sudden under GTCS, altered sensorium. The first diagnosis that came to our mind is the dengue encephalitis. So MRI brain has been done, and MRI brain showed that hemorrhagic infarct, multiple area hemorrhagic infarct, like hemorrhagic infarct in parietal cortex, bilateral thalami, bilateral parietal subcortical cerebral white button, and bilateral central semiovale. Then the reporting has been bit corrected that this is not actually infarct, these are the demyelinations with hemorrhagic changes. So, but there is no typical features of dengue encephalitis, but the feature is towards the demyelinations with hemorrhagic changes. So what is your diagnosis and how will you going to treat her, Mehta?
Yes, so you can see the for MRI that suggests there's the features that we call the acute hemorrhagic encephalitis or encephalomyelitis. And this patient, one possibility would be that looking the hyperferritinemia before the MRI before doing the MRI. So the secondary HLH with encephalopathy could be another possibility because the patient has bicytopenia and the high inflammatory markers. So coming to this entity, so this is a very severe form of you can say the ADEM, so demyelination along with the hemorrhage, and it's a fatal. So if you don't treat with this is the one of the antibody mediated the hyperinflammatory state. So if you don't treat with the immunosuppressant and appropriate time within the very rapidly, then the patient will have a high mortality rate. One thing that we should keep in mind that another entity that we see in the dengue patient is the ANEC, so the acute necrotizing encephalitis. So that happens in the maybe in the early first one within the first 2 to 3 days of involvement of the dengue. So that's the differentiation is important because for ANEC you have to give also the immunosuppressant, but the tocilizumab will be much more helpful there. But here the methylprednisolone and IVIG will be helpful. So this MRI will help you out. So here the mostly this hemorrhagic encephalitis, the white matter, the cortex will be more involved, but this ANEC, the basal ganglia and the deep gray matter will be more involved. Okay. And the inflammatory cell will be higher here in this acute hemorrhagic encephalitis. So that is the few points that you can differentiate. So early MRI and appropriate immunosuppressant is the key for success.
You need to do a very good MRI. By doing an MRI, you can differentiate a typical dengue encephalitis from ANEC, from ADEM, from HLE. So the treatment are different. If it's dengue encephalitis, you don't need to do anything. But if it's ADEM or HLE, you need to give immunosuppression even in ANEC, but role of tocilizumab is there. So coming to case 7, this 2 months old baby boy apparently well up to 7 days ago, sudden onset high-grade continuous fever for 7 days, excessive cry for 2 days, followed by single episodes of abnormal limb movement or GTCS on day 7 of fever, apparently subsided without medications. Was admitted in a sick infant care unit, developed intractable convulsion on the following day, thus shifted to PICU for further monitoring and management. Vital on admissions, he was irritable with excessive inconsolable cry, febrile, tachycardic, bit hypotensive, tachypneic, hypoxic. There was significant hepatosplenomegaly that can be appreciated well by parabdominal palpations. Other systemic examinations were normal. So, Dr. Nandita, what is the provisional diagnosis and how will you initially start managing this case?
So this is a 2-month-old, almost unwell for a week. So we would still rule out meningitis, encephalitis, probably viral or sometimes even bacterial. We'll have to rule out sepsis, group E, or since 2 months, we may have to rule out sometimes gram-negative sepsis too. Now, considering the hepatosplenomegaly, there is hypotension. I don't know the blood gas, probably considering the age group. IEM, I'm not sure fitting in, but the fever is a little unusual presentation. If it's a dengue season, of course, we would go ahead and do workup for a tropical panel too at that situation.
Yes. So what followed? The first diagnosis was definitely sepsis meningitis. So immediately intubated in PICU and put on mechanical ventilations, developed prolonged bleeding from cannulation site, suggestive of coagulopathy. Initially started on IV ceftriaxones and then changed to IV meropenem and vancomycin. Started on IV fosmanitoin to prevent further convulsions. Deteriorated further and was shifted to high frequency oscillatory ventilations. So we got the blood reports. There was a anemia, thrombocytopenia, sky high CRP, ferritin was high, and there was a prolonged coagulopathy with a non-coagulable blood. The prothrombin time was more than 120 seconds, and blood CS was no flag after 48 hours. With the chest X-ray, you can appreciate there are few opacities in the lung. The central line has been done, intubated. You can see the thickness of the soft tissue due to prolonged edema. There was a huge edema. Fluid overload was there. So he was continuously deteriorating, organ dysfunctions over the next 48 hours. You were on meropenem, you were on vancomycins, you were on inotrope, supportive therapy. So what's now, Dr. Sarkar?
Yes, so the patient still you have given the good antibiotic coverage, but still the patient have the multi-organ dysfunction and the inflammatory markers are high. So again the things that with the hepatosplenomegaly, and if you look at the blood picture, there is an anemia and also this patient. So the possibility could be here the tropical infections with an infection leading to any secondary HLH. Or the patient may have as the age is only 2 months, the primary HLH could be a possibility here. So if you get the reports, so sometimes we have also get some patients even in the early infancy getting this scrub typhus, getting this deteriorated, having the multi-organ involvement with the severe hepatosplenomegaly. So I will empirically start the doxycycline here and give the other organ support to the patient and see the response and wait for the report and simultaneously continuing the organ support.
Yeah, definitely in this case, considering the age, we did not send the scrub typhus initially, but after 48 hours of not responding, we have sent the scrub typhus. It came out to be positive. The baby had been started on IV doxycycline. Dr. Pathak, what will be your take on scrub typhus in infancy?
So basically, it varies from region to region. So we are discussing in detail. So when you come to my region, we have a lot of rickettsia, which is there rampant. So we even treat rickettsial fever on an OPD basis. So you see a rash, you see that there is a fever, a 7 days fever, and you don't get anything, a hepatosplenomegaly, a lymphocytosis, and sometimes an eschar. So we treat them very well. So for these babies, sometimes they get exposed to ticks and they get this thing. So we in our region, we see a lot of scrub typhus in infancy. And because if you see just some pointing points for a hepatosplenomegaly, though it's a rash negative scrub typhus. And one of the major differentials in our region for acute encephalitic syndrome is a scrub typhus.
Yeah,
So
definitely.
initially we start only with
specifically in the monsoon season.
Typically in monsoon season. So we
in this case, there is no improvement after 48 hours IV doxycycline. So Dr. Nandita, so we have proved the case of scrub. We have given IV doxycycline. So patient was not improving. What we are doing? Is a resistant scrub or something else is there? This is a repeat blood reports.
So I can see that red number ferritin, it's like sky high 21,000. So of course, where we have come across dengue and rickettsial causing this HLH or macrophage activation syndrome. So probably at this point, that's what we are dealing with, and probably I would go give the steroids at the earliest.
Yes, definitely. A developed hyperfertilemic sepsis of cytokine storm or HLH, what's in a name, whatever name you can give it. So most of the severe scrub typhus and dengue ultimately complicate into this hyperfertilemic sepsis. So we have started this.
One point, just Professor, so this the scrub typhus, if it is severe, now the few studies, especially from Vellore, they have shown that the combination of the doxycycline and azithromycin in patient with severe
yes.
scrub typhus will be more helpful than single doxycycline. So that we can consider.
This patient has
Even-
started intravenous immunoglobulin and IV methylprednisolone. So ultimately, he required lots of things, high frequency ventilators, RRT. We can see how much swollen the kid was. So we have to do a peritoneal dialysis for these patients, put on a high frequency ventilations, and ultimately he went home. So landing point is that infants, even neonates. We got 2 cases of neonatal scrub presenting with fever with features of sepsis meningitis, like with hepatosplenomegaly. So usually the bacterial meningitis sepsis does not present with hepatosplenomegaly. Specifically in the monsoon season, in our part of the country, even in west, south, I don't know about the north, scrub typhus must be ruled out.
Just one more point, Dr. Prabhas.
Yes, yes.
The other differential for this kid would be HSV, okay, and this age.
Yes, definitely.
HSV can present like this. And second is, I would still work him up for primary HLH. So your scrub IgM is positive, but we are not sure how these kids present.
Yes, in all these cases, this smaller kid when developing the HLH, we usually say the exam panel to any syntaxins or perforin deficiencies or there or not. Okay, so this is a combined publications from Institute of Child Health, leading by myself, and Medical College Kolkata, leading by Dr. Mihir Sarkar, that severe scrub typhus infection in infancy with multiple organ dysfunctions, a retrospective observational study from Eastern India. So we're going a bit quick. So this 4-year-old kid, history of low-grade fever for 3 days, extreme irritability and altered behavior for 2 days, altered sensorium with convulsion for 1 day. On admission, GCS was 6 by 15. No reflexes were brisk, profuse secretions was there, extensor posturing was there, intubated, ventilated. So what should be your clinical diagnosis? What specific investigation you want to do? What should be the initial management except the organ support? Dr. Mir, very quickly.
Yeah, so specifically, so this is the patient of the acute encephalitis syndrome. Okay, so and if you look at this, the clinical picture, this is the hyperextension neck and the deep tendon reflexes that indicates that maybe the involvement of the basal ganglia and the thalamus region. So that could be the etiology that you can consider according to that. And specific investigation, of course, you have to do immediate CSF study if the patient don't show the very high features of the ICP, and the MRI brain, and the other basic bloods you have to do. Take that focused history if there is something with the history that you can identify any causative to the to going to the.
What empirical antibiotic you want to start?
Mine is because the malaria still is here a high incidence of the acute encephalitis syndrome. Will start with the ceftriaxone, acyclovir, doxycycline, and the artesunate here in our center.
So everybody agrees that we should use doxycycline as an empirical therapy in acute encephalitic syndrome. We started using it for the last 3 or 5 years.
Yes. So it depends upon the epidemiology. So if you're getting cases, you should use it. And doxycycline is a very good drug for other resistant organisms also.
Yes. Okay. So this is the MRI report. After getting the MRI report, the radiologist rang me up and asked me the total history. Again, he rang him up, asked me the history, and he's telling that I am going to make a very rare diagnosis. You please take history again, whether you're missing anything or any history of dog bite or not. So then he went through again, and here is the history of dog bite, category 3, 1.5 months back. Actually, it is category 3, but it has been categorized as category 2, and the kid did not receive any immunoglobulin. So the MRI reported as the brain shows features suggestive of abnormal signal intensities in bilateral basal ganglia, thalami, brainstem, and visualized spinal cord. Possibility of rabies encephalitis needs considerations. So he shifted to isolation IT facility of ID and BG hospital, and there saliva sent for PCR. Rabies virus has been detected after a few days and succumbed after 3 days. The learning point is that from that, because when the patient has been diagnosed with rabies, there's a huge panic went among the ICU staffs. Those who have handled the ICU staffs, I have handled these patients. My resident has intubated these patients. There's a huge panic. Though theoretically rabies cannot be transmitted from human to human, but there are a bit chances of transmissions. The huge panic. All went for a rabies vaccinations. Few went for a rig also. So for these types of cases, from that is a learning point. So we started taking the history of dog bite. So history of dog bite should be taken each and every cases of AES, I think actually.
So we
Dr.
have a
Nikki has a
surviving
one
case.
case report, no?
So we have a surviving case report for rabies.
Yes.
31st surviving
Now
case.
there are a few isolated case reports from pediatric and adult
So
coming
we
that
did was CSF. We documented CSF immunoglobulin, serial immunofluorescence immunoglobulin from the CSF, and we also did skin biopsy. We also did the saliva, and we documented the increasing titers also.
we're running short of time. I have two more
Yes, sir.
cases. to go through. So this 21 days old infant present with a cough for 2 weeks, fever for 1 week, minimal respiratory distress. Cry reflex activity was good on full breastfeeding. Temperature was 100.5 degrees Fahrenheit. Respirator was 48 per minute. There was mild intercostal retractions. Saturation varying from 92 to 96% in room air. What is your diagnosis and how will you proceed, Dr. Nandita? Very quick.
So it's a 21-day-old, so probably with chest retraction, I would think of still pneumonia or sepsis. So send a respiratory panel, then basic CBC. Since it's 21 day, I would even do a procalcitonin and CRP chest X-ray blood cultures and start on broad spectrum antibiotics and see the X-ray report.
So definitely the diagnosis must be a broncholytic illness and pneumonia in this speed of child. Routine blood has been sent, chest X-ray, IV antibiotics. So CBC was normal, CRP was 4 times, and this is the chest X-ray of the kid. So Dr. Nikhil, any special investigation after seeing this chest X-ray?
So if you see, this is a chronic disease. A 2 weeks organism is staying in the baby, and the baby has not deteriorated very badly. So neonates are known to deteriorate very badly with sepsis. So this is a slow-growing organism,
Exactly.
which we should keep in mind. So we should take again history in proper. So we whatever is the maternal history of Cox is there, or any contact is there, or any other thing. So and
Mother
the
had a
chest
full history of abortion previously.
Abortions, but there is no history of Cox. But if you see, the liver is also enlarged. So X-ray, with the X-ray, you can say that there is a enlarged liver there, and there is a diffuse pulmonary involvement on the left side. So we have to think of an abnormal organism. Again, I would prefer to do a BAL for this kid because 2 weeks fever, still not responding to antibiotics. I would like to do a BAL for the kid and keep in mind a resistant organism or organism which is not routinely covered by your antibiotics.
So I have sent
A torch may also be kept in mind. The CMV
virus is also a possibility. So first thing first, you have sent a basic test. You have sent a gastric lavage. This is a real picture taken on the microscope. This acid first bacilli was positive in the gastric lavage. So we have diagnosed this case as congenital tuberculosis. Dr. Manu, your take on congenital tuberculosis, very quick.
I think you've already put it there. Like you have, there has to be a good history. You have to start the treatment immediately. I think it's rare though. It's rare.
So, though this case has not been seen by me, this case I took from my teacher, Dr. Apurva Ghosh. But after this case, we got already another 4 or 5 cases of congenital tuberculosis.
Wow.
Okay. So learning point is that in India, tuberculosis should be kept in DD in any lung pathology in any age group, even in a neonate, even in 90 years old. Last case, the 3.5-year-old male, it's a fever of high spikes for 12 days, pain abdomen with abdominal distension for the last 6 days, chest was clear. Abdomen was distended, but no free fluid was there. There was hepatomegaly, other systems was normal, vitals was stable. Total count, neutrophilic leukocytosis, platelet on the higher side, CRP was sky high, amyloid lipase was normal, high spiking temperature was there was tender hepatomegaly, increased inflammatory parameters. So we summarize in a nutshell, he had a fever, pain abdomen, hepatomegaly, breast, TLC and CRP. What should be the empirical diagnosis? Mirda.
Yes, so the patient has a prolonged fever, almost 2 weeks fever with a high spiking fever and the high CRP and the raised total leukocyte count, hepatomegaly. So anything related to any liver that or maybe the pleural pathology or the pericardial that may lead to the hepatomegaly along with this increase and the pain abdomen and the deterioration. So there may be some collection in the past. So it may be either liver abscess or it may be the past collection in the either peritoneal cavity or the pleural just above the liver or the pericardial. But you have already given the picture that the chest and the other things are normal. The CVS examination, we have to go in details. Given on that history, the liver abscess could be the most possible.
Definitely. When this case admitted, I was the admitting pediatrician, so I was quite sure there is a liver abscess. I asked my resident, they please go for a USG now, and I will get a liver abscess. Then put the patient on ICU. I will do a tap or do the pigtail. So I was very sure. I went in the ICU preparing myself to put a pigtail. Definitely, next investigations is definitely USG whole abdomen. So it surprisingly, the USG whole abdomen revealed a hepatomegaly, but no abscess. The splenomegaly was there. Incidentally found some pericardial fluid collection. So I did not believe the report. So I brought the child on ICU again. I did the USG by myself. I also got the hepatomegaly, no abscess. But I also got that some pericardial fluid collections were there. There are definitely a lot pericardial fluid collection was there, and development of the few septations were there. So then my diagnosis has been changed from liver abscess to pyopericardium. So what next, Dr. Nandita?
So we'll have to get a formal echo done now just to know what's happening. Are there really septations or because it's a purulent pericarditis? So if possible, we'll have to do pericardiocentesis and see if we can get some culture from that.
Definitely.
For tamponade too, because
Common echocardiography has been done. It shows that there's a pericardial effusion, moderate pericardial effusion with strands. Antibiotics, we already started on IV meropenem and clindamycin. We have tried a pericardial synthesis, but it failed. Within next 48 hours, the boy deteriorated. Then the echo revealed impending tamponade. But the main pericardial collection was in the posterior part. So I was not able to incite the pericardial space through any approach. So we are not able to do the pericardial drainage. So ultimately, we have to call the cardiothoracic surgeon, and the thoracotomy and pericardiotomy has been done. And this is the intra findings. You can see there are some cheesy materials seen in the heart, inside the heart, and the fluids was serous. So the cardiac surgeon was very sure that this is a sure shortcut of TB. These are typical cheese-like appearance of TB. And he started scolding us that you are not able to diagnose a TB nowadays. So we have to open this heart like this. There's no pus was found, only serous fluid. Multiple fibrinogen strands and deposits were there. There was 12,000 cells, neutrophil 40, lymphocyte 60. Protein was high, LDH was a bit high. ADA was normal, glucose was low. Ground stain, CS, AB stain, CV net was negative. So it was not fitting totally with the pyogenic. It was not fitting totally with tuberculosis, but few of the features are suggestive of tuberculosis. So what should be the provisional diagnosis if you these types of pericarditis you get and this pericarditis fluid report?
I think the way the patient presented, it looked more of bacterial pyo, than TB to me. And histopatch should show you if this is TB. HPE is so extensive, HPE should tell you. And if they've gone in, they can strip and send it. So I don't know, I'm still not convinced it's TB, but of course it's such a severe disease in that area. We end up starting and still figuring out what could else it could be.
Yes. So definitely we are not certain about the TB, but the cardiac surgeon was very dominant. That I have seen lots of these types of cases. This is TB. Send the HP. You need HP to take some time. So taking a TB pericarditis with a bit doubtful mind, you start an ATD plus steroid, and the fever subsided after 3 days. Inflammatory markers came down, and you discharge the diagnosis of tubercular pericarditis. But this is not the end of the story. The boy came back after 10 days when steroid tapering had been started. There was new onset fever spikes. This time he came with an evanescent rash. Could not extend both legs and swelling of the knee joint. You can see swelling of the knee joint. You can appreciate the rash. So do you want to revise our diagnosis? Nida?
Yes, so now it is the time to retrospect. So, this patient having this pericardial effusion, the serositis, along with that responded to the high fever with other liver hepatomegaly. So now the patient still responded. As your history says, that responded to steroid. When you taper down the steroid, patient having the fever, rash appearance with the joint involvement, so arthritis. So this all features going in with the evanescent rash going to the systemic GI. That is the very unusual presentation with the sometimes it is an infection mimicker that we miss sometimes.
Exactly. This is an infection mimicker and systemic GIA, and we had a very robust rheumatology unit. And I worked for the rheumatology unit for a few of years, and we have seen almost 30 to 40% of systemic GIA initially presenting without any arthritis. And now it's considered it's not to be actually a GIA, it had to be a auto-inflammatory disorder. As now our planning has been there, that proposal is there, whether we can take it out from the typical GIA. So this patient was in the fever, rash, pericarditis, hepatomegaly, and arthritis, and actually responded to the steroids that have been given with the ATD. So it started on IV methylprednisolone 5 mg per kg. Fever subsided after 3 days, but reappeared after 24 hours. She developed a fixed rash and hepatosplenomegaly. Repeat blood counts showed high CRP, falling counts, deranged liver functions, coagulopathy, hyperfibrinogenemia. Definitely, ferritin was 58,000. He developed a macrophage activation syndrome. Started having seizures, became obtunded, ventilated, intubated. So rapid deteriorations, very poor cardiac functions, refractory hypotension, on multiple inotropes, IV methylprednisolone pulse, IVIG, severe coagulopathy, MODS. Then we had to use rescue anakinra. Fever gradually subsided, ferritin came down, cytopenia reversed, extubated after day 9 of mechanical ventilations. So final diagnosis was systemic GIA present with the isolated pericarditis, and they developed macrophage activation syndrome. So landing point is that all fevers and POs are not infectious in origin. High spiking fever, still patient doing better in between the spikes of temperature. Presence of rash, mucositis, pericarditis, arthritis, high platelet, not responding to usual antibiotics, suggestive of some non-infectious inflammatory disorders. We have seen lots of cases of systemic GIA has been treated with IV antibiotics due to it is present with neutrophilic leukocytosis and high CRP. Lots of these cases has been treated as septic arthritis outside and ultimately complicated very badly as macrophage activation and landed up in our PICU very badly. So thus we completed our 10 cases journey. So thank you, my all panelists, and thank you the listeners for your patience sharing.
The more important thing in the last case would be just such a high CRP and not getting any organism.
Yes.
We should have looked out for something rheumatological, because it was a prolonged fever, there was a splenomegaly, there was a pleuritis, and my teacher taught me that any CRP which is in 3 digits, you have to think of an inflammation or an inflammatory disease along with infection.
Definitely.
Agree. Yes. So very nice array of cases with the all type of infections. Thank you, Provost.
And we have started this PID in PICU when there are lots of organism is there, and the kids were fighting after the expert opinion of all our 4. Now the kids are doing well, they are happy.
Prabhas, can you just stop sharing?
Yes.
Excellent. What a journey. Amazing. And there are a variety of cases, I must say. And all have been worked out very nicely with the perfect diagnosis. I think there are a lot to discuss, a lot to say by experts, which I've seen on the screen. So I'll first go to Dr. Darul Rangnath, sir. Sir, your comments. Sir, you are muted. Unmute, sir. Okay, sir.
Sir, done. Am I audible?
Yes, sir.
After 14 or 15, what I wanted today, I have seen. There is totally presentation of case, discussion about age, how to approach and what should we do, what should we, within the span of time that is available. That is, we are running against the time. Even then, they have worked nice and all the cases are interesting. Rabies, which is my favorite subject, has been come as a presentation with an alter, and the tuberculosis, which is regularly seen previously, now it has become rare. That's what we think, but it is presenting in a different way. These are my observations from the presentation. Thank you very much for all the participants.
There is one interesting comment in the YouTube I would like to read out. I don't know. Dr. Ramakrishna, is such acute severe presentation expected with mycoplasma in, I think, with reference to your mycoplasma case? And second thing, there is somebody was Dr. Ashwani Kumar has said from this platform, these type of recommendations should not be advocated. I think that is regarding maybe steroids. So, Dr. Prabhas, you would like to comment upon that?
If I get any time, any day, 1 hour or 2 hour, I can show my mycoplasma series. You can see the some of the for the last 2 epidemics, we got lots of epidemic. It will take almost 1.5 hours to present my severe multi-organ dysfunctions mycoplasma cases.
Yeah, we saw everything, right? We saw CNS really bad
Everything.
manifestation. We had clotting in the
The
spleen.
important take home is it's not the end. Every case we use steroid. We treat even mycoplasma on OPD basis. We treat the mild cases only. The important thing is we were discussing what was the terminal cases and extreme end of the mycoplasma where steroid was used. We don't use it in all cases. And that should be the take home message. I think the take home message should not be that we are giving a take home message that steroids are being used. The more important thing is just presenting that this is the extreme variation of mycoplasma. Routinely, even azithromycin or clarithromycin is good. Levofloxacin is also good.
Yes, the mycoplasma with multi-organ dysfunction is usually the hyperinflammatory state. So it is not that directly infection that is causing the organism. So that's why some sort of control of this hyperinflammatory state should be administered.
Chetan, can I add? Can I add
Yes,
something to
yes.
that?
I'm going to come to you only. Yes.
No, for this mycoplasma, I'll come
Okay.
later. I have
Okay.
You finished off, I'll come back.
Okay.
Or I'll finish the mycoplasma alone.
Yes, mycoplasma, please.
Yeah, 2 or 3 important points. In fact, for youngsters, it's very difficult to remember all this. For elderly people like me, some mnemonics will help. I remember the rule of 3 for mycoplasma. I'll tell you what the 3 is. Generally, typical pneumonias respond within 3 days. Any community-acquired pneumonia, if you give a beta-lactam, 9 out of 10 will respond in 3 days. If the child doesn't respond in 3 days, you start thinking of mycoplasma. So that is rule number 1 in the 3. 2, 3 drugs are available and used for mycoplasma: azithromycin, doxycycline, and levofloxacin. Of the 3, you look at the data that is available. You can go through Cochrane review also. There is no evidence to suggest that antibiotic therapy alters the course in uncomplicated mycoplasma pneumonia. Whereas there is thin evidence that in hospitalized children with severe mycoplasma pneumonia or adults with mycoplasma pneumonia, antibiotic therapy may favor the host. The next is the rule of 3 in mycoplasma comes very handy. You give beta-lactams for 3 days. There is no response in 3 days. You start azithromycin, no response in 3 days. You start the alternative drug. Another 3 days, or the child is worsening, and the inflammatory markers, the Chinese depend a lot on LDH and also on ferritin in mycoplasma, surprisingly. They do, and the LDH and ferritin are high in spite of trying azithromycin, doxycycline, or even levofloxacin. Then the recommendation is that you should give steroid. Nobody need to be apologetic in giving steroids. The only caution is, please keep looking for an alternative diagnosis. You have no business to miss a tuberculous pneumonia and give steroids and doxycycline or levofloxacin. You have no business to miss a nocardia, no business to miss a PCP. So be careful. So at every stage, with the rule of 3, keep looking for alternative diagnosis and then take the step. The next rule of 3 is that for 3 days, you give intravenous methylprednisolone 1 milligram per kg 3 times a day. That is the recommendation as per the recent protocols, where the Chinese have arrived at a consensus. 1 milligram per kg methylprednisolone 3 times a day for 3 days. If these 3 days, the child's inflammatory markers are not better, general status is not better, then it is refractory mycoplasma pneumonia, for which you'll have to consider IVIG with pulse methylprednisolone as suggested by Dr. Manu Chaudhary. You have to treat like CRS. That is the protocol. So nobody need to be apologetic about giving steroids for a confirmed case of mycoplasma when you don't have alternative diagnosis. When everything fits into mycoplasma, you're proven by PCR. And in fact, today, we have facilities to do NGS for mycoplasma with drug sensitivity also. We have done for a few cases. Surprisingly, in India, the only paper that is available on the PCR for mycoplasma is from Chennai Tharamani Institute, where they have shown no resistance to azithromycin. Much more data is needed. We have done for a few cases PCR from pleural fluid or from the bowel, and all of them had shown no azithromycin sensitivity. But I can tell you all the cases required levofloxacin for improvement. They didn't respond to azithromycin. That is regarding mycoplasma. Second comment I had regarding the scrub typhus. People are talking about combo or single drug therapy. New England Journal, April 2024, if I am correct, CMC Velour, combo therapy, the outcome in adults has been better, but there is no data in pediatrics. There is no recommendation. There is no data on resistance of rickettsia to azithromycin. This is just a clinical study of combo drugs. Currently, in fact, we see quite a lot of rickettsial infections from Andhra Pradesh and Chennai. They respond beautifully to doxycycline. In fact, in our unit, standard practices, we don't use azithromycin for mycoplasma. We straight away give only doxycycline to cover also rickettsia. That is it. The other comment I had was regarding the voriconazole in the case 1. I heard voriconazole is given orally. I'm not sure how it is right, though, to use voriconazole orally for a CNS infection. Dr. Manu might add to it. I would be scared to use voriconazole oral for such a lesion. Dr. Manu, your comments on that?
We started with IV. We transitioned to oral very later on. Like this case, we did 6 weeks, right? You did it first.
No, in fact, in that case, I would give for 12 weeks IV. I don't think I will give oral at all for the child.
We can switch, sir, if you're getting your therapeutic levels. That's what the IDSA says, and that's what we practiced.
Okay. Then 2 other organisms which can cause pneumonia, which can get missed, are Burkholderia. Burkholderia, sometimes, it takes longer than Pseudomonas for the cultures to become positive. The report may come late. So that is one organism which may fool us. It may not respond to your routine beta-lactams. And of course, I don't know, Manu, you can add. Legionella, we have been looking for it. In fact, in my 40 years, I have seen only one case of proven Legionella. I don't know. But in the West, they report quite a few cases. In pediatrics, we don't see Legionella. And Legionella, you have to give azithromycin for 14 days. 7 days therapy might not be enough. Last comment is on congenital TB. And youngsters listening to the program should know, in spite of high incidence of tuberculosis, congenital TB is very, very rare. It's not that we miss it. It is because endometrial tuberculosis leads to sterility. That's the reason why congenital TB incidence is very low. It's not because TB is not there or TB is missed. Congenital TB is extremely rare because many women with endometrial TB will not be able to conceive due to endometrial tuberculosis. That's why it is very rare. In fact, we published a case from our unit where we were surprised to get a call from microbiologist. Child had pneumonia, very well-nourished child, well-nourished mother. AIB was positive. And finally, endometrial cultures of the mother proved the tuberculosis, and we could prove the same strain was there in both of them. So it's very difficult to diagnose unless you think of it. But if you find hepatomegaly with a bronchopneumonia, unilateral or bilateral, young infant, please do a gene expert and look for congenital TB.
So in
My
our
last-
case, the mother developed pleural effusion after 2 months.
Yeah, that's what. In fact, the case we reported, the mother was obese and healthy. She was healthy. With great difficulty, we had to convince her for investigations for proof of tuberculosis in the mother. So that's the story. So it's quite uncommon. It's not that we miss it. It's not that the diagnosis should be obvious because the neonates are almost like immunodeficient. They have a lot of ARB in their respiratory system. It's very easy to pick it up. Last comment, in the pericarditis case, I was surprised with the diagnosis of SOJAA. I think you should be monitoring the child. I think the diagnosis is still not complete for me. I would keep monitoring the child for development of some other vasculitis for which the child is now manifesting. It may even be a SLE. You never know. It's very unusual. And of course, the moral of the story in that case, I think in 2025, don't listen to the surgeons and start empirical ATT. Listen to your microbiologist. Thank you.
Excellent. Happy to see one of the renowned intensivist, Dr. Mahesh Mohite. Sir, I don't know when you joined, but your comments on the whole session.
Actually, I was busy in the PG teaching session, so I joined after almost 4 or 5 cases. But what a collection! Amazing.
Fantastic.
Absolute. I just wanted to make 1 or 2 comments. In fact, about these tropical fevers, there is a wonderful document already published in Indian Pediatric, as well as I think it was actually a committee commissioned by ICCM of 8 professors of lead institutes in India, Dr. Sulit Singh being one representing pediatrics and 7 being other adult. There is 2017 published, which is a document on cluster approach to tropical infections in PICU. All should go through that document. It will give you a proper, all that, most of the thing that we discussed here, you will be getting it. That's one comment. Second, I think people are underestimated still. Tocilizumab in NEC, we feel that's a lost case. Even the literature world over gives a mortality anywhere between 30 to 70%. But we have used tocilizumab in certain cases, few cases we had an opportunity. If it is received within first 6 hours, believe me, we had almost intact survival. A classical NEC case, intact survival. So people should be having an access to that drug. Otherwise, it's a near certain death. The last case which you mentioned about pericardial effusion with SOGI, I would have kept one more differential of brucella. Brucella would behave like that. A pericardial, joint, rash, rapid deterioration. I have come across this kind of a dilemma. Ultimately, it turned out to be because incidentally the lab gave brucella IgM positive in that case. So we were kind of bifurcated or kind of misguided to that. Ultimately, it turned out to be SOGI. But with that kind of a combination, always keep one of the differential in Indian circle. He had organomegaly, he had a pericardial, he had cardiac involvement, he had joint involvement. So keep brucella as one, and he had 2 weeks of fever. And last but not the least, kind of collection we have at an individual level, Dr. Giri could present those 10 cases. I'm sure in India there must be 100 who are having such a huge variety. We keep quoting IDSA and whatever kind of international guidelines. So Dr. SBS sir is there. All our seniors are sitting here. It's time that we should write the tropical fever guidelines given to the world rather than quoting IDSA and all. Why this kind of thing is not happening? I think your Pediatric Infectious Disease Group should seriously think. I think the amount of collection we have, and we have facility for every diagnosis today. I don't think we have anything which is, at par with anything in the world, So why they? We should really think in that direction. We should write the guidelines for all the statement rather than looking at east or west. I want the opinion of seniors. This is a real right time that we should have a sort of a good kind of. How many cases? Lakhs of cases we have. No country in the world must be having that many cases in one single country. So we should really take this forward. So much of huge variety of cases. And that's all is my last kind of submission. Thank you very much.
Thank you, sir.
Prabhas, just one final comment I wrote down. I forgot to tell you. I think that SOJ AAK, you should do a immunodeficiency workup. You should do it. It's a must. The game is not over. I wouldn't close the file.
Yes.
So actually, the case is already 3 years old now. The child is doing well.
CGD, I think CGD, the granulomas can be because of CGD as well.
Amazing.
So absolutely, it was a treat.
Hats off to Giri. Hats off to Giri.
Yeah. And this is what I expected from him, because when we decided to take this session, when we were in Kolkata together, me and Dr. Bhaskar, right at that moment we decided, let's next time we'll have Dr. Prabhas, because the way of like the collection he is having, he is today to his expectation. Thank you so much, Dr. Prabhas, and wonderful panel. What an perfect and very important input from all the panelists. Thank you so much. I don't have to say anything more. Before that, I can conclude. I'll request Treasurer Dr. Yashwant Rao to say a word of thanks.
Good evening, everybody. Last month, we had Mahesh Kore, sir.
Yes.
A lot of interesting cases. The link 11 were 10, now 11 is proving more interesting. Dr. Prabhas collection, excellent collection, and learning points which he has given, we should never miss. Rabies and encephalitis in AES, scrub typhus are really good. I thank Prabhas Prasanagiri sir, Nandita ma'am, then Mihir Sarkar, our Nikhil Pathak, and even Manu Chaudhary madam for sparing their valuable time, and we did not even feel time, even if half an hour more. And lastly, comments from Balasubramaniam sir. Rule 3, we'll never forget. Thank you so much. Thank you, everyone.
Thank you so much. Thank you.
Thank you. Good night.
Good night.
Thank you, everyone.
Thank you.